routine work that we do at CDC. So I just want to start like I do with most of my presentations. I'm not going to try to steal Dr. Chatham-Stevens' thunder on vaccines, but really vaccines are authorized in the United States continue to be remarkably effective in reducing risk of severe disease, hospitalization, and death, even against the widely circulating Delta variant. And vaccination is still the most important public health action to end the pandemic. And so I love to start off all my presentations just giving that shout out to the importance of vaccinations. We're certainly not where we had hoped we would be at this point in the pandemic. Last week, CDC reached a milestone. It was our 600th day of the COVID response within our own internal activation. But we remained dedicated to following the science and to help in this pandemic. As you've seen in the news, the COVID-19 cases, hospitalizations, and deaths continue to increase, especially in areas with higher levels of community transmission and lower vaccination coverage. For those of you who really like to dig into the data, in June, we were averaging around 12,000 cases a day. And on August 30th, the 7-day moving average of cases reached over 147,000 cases. So it's a really dramatic rise in cases in a very short period of time. The week-to-week comparison of average daily cases has increased 3% over the last week. Hospital admissions are stable at 12,000 admissions per day as a 7-day daily average, and deaths have increased by 17%. So numbers are not really where we're wanting to go. We're monitoring closely, but we need everyone to do their part. Importantly, though, while we are seeing higher case numbers compared to waves experienced last summer, we're creeping up closer to some of the highest numbers that we saw throughout the pandemic during the winter months. A bit of good news is that we're seeing 70% fewer deaths, and this is largely due to the impact of the vaccine. So that's a bit of good news. Healthcare systems are being strained in many states with surging cases that's impacting providers' ability to deliver care, not only for COVID patients, but also for other healthcare needs. So this is a real pivotal time for us. The emerging evidence about the Delta variant demonstrates it is a formidable, more formidable than the original type, wild type virus. The Delta variant has most recently surged to become the predominant variant. In May, it was less than 1% of the circulating virus in the country, and now it's over 99% of cases here in August. So it's really the only thing that's circulating in this country. Delta spreads more than twice as easily from one person to another compared with earlier strains. Currently, 96.5% of US counties are in high or substantial transmission category. For those of you who aren't familiar with how we define that, high transmission is defined as 100 cases per 100,000 residents, and substantial transmission is 50 cases per 100,000 residents in an area. So essentially, again, the whole country's bright red with lots of transmission. CDC has a robust COVID data tracker website. I hope that most of you have visited our website. This is an unprecedented step in sharing in near real time all of our surveillance data around the pandemic. And I can share that link in the chat function after. We have information on cases, hospitalizations, deaths, and vaccination all the way down to the county level. And I encourage you to visit to really understand how your community is impacted. And we add new features all the time. And it's a great way to really be able to look at the data and carve it up in many different ways. Some data suggests that the Delta variant might cause more severe illness than previous strains in unvaccinated persons, and unvaccinated people remain the greatest concern. There's the greatest risk of transmission among unvaccinated people who are much more likely to contract and transmit the virus. Because of these concerning developments, CDC announced new recommendations in late July. In areas with substantial and high transmission, CDC recommends that fully vaccinated individuals wear a mask in public indoor settings to help prevent the spread of Delta and protect others. We also added a recommendation for fully vaccinated people who have a known exposure to someone with suspected or confirmed COVID to be tested 3 to 5 days after that exposure and to wear a mask in public indoor settings for 14 days or until they receive a negative test result. CDC recommends that public health practitioners and organizations prioritize prevention strategies for indoor settings. It's that layered approach that we have been recommending from really the beginning of the pandemic. There's no one single strategy that's going to completely prevent or be 100% effective in preventing transmission. And that's why these multiple interventions should be used at the same time to reduce the spread of disease. Proven effective strategies against COVID transmission beyond vaccination include using masks consistently and correctly, maximizing ventilation both through dilution and filtration of air, and maintaining physical distance and avoiding crowds. Basic public health measures such as staying home when sick, hand washing, and regular cleaning of high-touch surfaces should also be encouraged. OSHA also recently issued updated guidance on mitigation and preventing the spread of COVID-19 in the workplace. So they, at this point, as the lead federal agency on occupational safety and health, they have issued the guidance now related to workplaces. So I encourage you to visit OSHA's website to learn more about their recommendations. We're working closely with OSHA to make sure that their guidance is in alignment with CDC's changing recommendations. We know we do follow the science, and sometimes our interim guidance does change, and we work closely with OSHA to make sure that the information is in alignment. So with that, I'll turn it over to Dr. Chatham-Stevens to hear more about where we are with vaccinations.
Great, thanks so much, y'all, and apologies for joining late there. So yeah, I mean, just to really echo what Captain Delaney said, our main message really is that the COVID-19 vaccines continue to be safe and effective. And I think there were some big developments this week, and we anticipate some big developments over the next month or two. I think you all may know that the Pfizer vaccine received full approval from FDA and an official recommendation from the CDC's ACIP, the External Advisory Committee. So that was a great step and really highlights how safe and effective the vaccine is. And I'll start off by talking some about the safety, because we do know that there's still some concerns regarding the safety of these vaccines. And just for some background, in the clinical trial phases, there are tens of thousands of people who got these vaccines. And then to date, outside of those clinical trials, we've had hundreds of millions of people just in the US who have received these vaccines. So the most recent number is 443 million doses with 174 million people being fully vaccinated. So if we just take a step back, that's pretty staggering given how efficiently we've been able to get these vaccines to people. And I think another key point that we're really trying to emphasize is that everyone who's received these vaccines, including me and many of you, have received these under the most intense safety monitoring in US history. So there are multiple groups that are involved, including CDC, FDA, and other federal agencies that are constantly monitoring the safety of the vaccines. And we also know our counterparts around the world are doing that as well. So just to kind of briefly recap some of the side effects, after getting a vaccine, some people have no side effects. Others, like myself, have had some of the more common side effects, like fever, headache, and muscle pain. So those are not uncommon by any means. And fortunately, the safety monitoring systems have found some of those serious types of health problems after vaccination, but fortunately, these are quite rare. So to us, this reflects the fact that these safety monitoring systems are working in the fact that they're picking up these very rare events. And so that's just some of the safety. I'll transition over to talk about some of the effectiveness of these vaccines. And like Captain Delaney mentioned, all three of the COVID-19 vaccines being used in the US really help protect against COVID-19, especially severe illness, in clinical trials and in the real world setting as well. They reduce the risk of COVID-19 and its potentially severe complications, most importantly being hospitalized and dying. And in a couple numbers that I have found really helpful to me to understand this is that if you get vaccinated, your risk of infection is approximately 4 times lower. Your risk of getting ill from COVID is over 8 times lower. And your risk of hospitalization or death is around 25 times lower than someone who isn't vaccinated. So I think that just helps put it into context for me. I think Captain Delaney mentioned this already, but I just wanted to re-emphasize it is, we're seeing a surge of cases now But even if we look at this surge compared to cases last summer, deaths are down more than 70%, thanks largely due to vaccination. And I think we've all probably seen this in the media, but a lot of the recent data continues to illustrate that most of the patients being hospitalized for COVID-19 these days are unvaccinated, right? So I think it really emphasizes the importance of getting vaccinated. And we know these vaccines are working well, but we do know that some people who are fully vaccinated against COVID-19 will still get sick because these vaccines, even though they are effective, are not 100% effective. There's no vaccine out there that is 100% effective. So as a result, some of these vaccine breakthrough cases are expected. But what we're seeing is that even though there are some people who get vaccinated can still get infected, overall their illness is less severe. Right, so they're getting less sicker, they're less likely to end up in the hospital or less likely to die. And Captain Delaney mentioned the variants already. I think we're continuing to track the known variants and kind of keeping an eye on what may be coming down from around the world in terms of new variants that are out there. So far, we're continuing to evaluate how our vaccines are performing against the variants, and overall, the data still indicate that they do continue to protect us against severe illness from the variants such as Delta, and we'll continue to monitor this and message on this as we learn more. So just to briefly recap, the COVID-19 vaccines are safe and effective, and it's kind of the best way for us to begin to engage in some of our pre-pandemic activities. If you have questions about whether you or a family member or a friend should get the vaccine, then I definitely encourage you to reach out to your healthcare provider. There are obviously fantastic sources of information, not only about your medical history, but also the vaccine as well. So I'm definitely encourage you to reach out to them to discuss further. And with that, I'll go ahead and end. Thanks so much.
So Lisa, any other comments?
Yeah, I'll just say I did put in the chat box the link to the data tracker website in case people wanted to go and play around with the data and sort of see the visuals. That's available in the chat.
Great. So I I'd sent you some questions that employers have had, and I was hoping that you could respond to those. I'd read the questions if you would, and then respond, and we'll see if other people have some comments they want to make.
Yeah, Kevin and I have kind of divided up the questions based on the content. So I think the first one, Kevin, is, will everyone need to have a booster shot? Yeah,
I mean, I think that's a spot on question. It's obviously been top of mind for a lot of people, especially when HHS and the White House announced the plan last month to have boosters available for folks starting sometime in the fall. And so right now, the goal is to continue to evaluate that data and understand if boosters are needed and who should get them. The official recommendation right now is that no one needs a booster right now, as we're continuing to evaluate the data. What we anticipate will happen over the next several weeks is that, I mentioned already CDC's External Advisory Committee, ACIP, they will meet to discuss this further. They've already brought this up in a couple of their previous meetings. FDA just announced that their external committee, which is VRBAC, will be meeting on the 17th to discuss boosters as well. And so we anticipate at some point that FDA will make an announcement, release their regulatory action on boosters, at which point then the CDC ACIP committee would meet again to make official recommendations. And just to let everyone know, this booster announcement is really pending full FDA review of the data, as well as CDC's ACIP making the official recommendations also after fully reviewing the data. Just to give folks a heads up, at this point, it is looking like there may be a more prioritized approach. So instead of, on X date in September, everyone is eligible for a booster, it may be a more prioritized approach, similar to what was used in the early phases of the vaccine for everyone. So it may be that initially the boosters are prioritized for people who are at severe or at increased risk for severe disease, such as those in long-term care facilities, those over a certain age, that could be 65 or 75 or another age, and then also people who may be at increased risk of having COVID-19 and transmitting it to others and being out of work. So we're thinking potentially healthcare workers in that particular instance. So I will say no one needs boosters right now. There's no official recommendation, but definitely stay tuned as we learn more about this and as the official recommendations come out.
Could you comment a little bit, though, about the impact of boosters? Some people have said that it dramatically increases the protection. Others are saying they're uncertain that how the impact might be on different people's health, that because the length of the protection is not necessarily known. Is it really like a flu shot that's good for about 6 months? Or do you expect that this is going to be an annual basis? Would this be something that would be perhaps combined with a flu shot? What's your thoughts about the direction there?
Sure. So yeah, the optimal timing of the booster, I'm sure, the initial HHS announcement was 8 months. We've also heard 6 months, and in the media, there's even been mention of 5 months. And so I think the exact timing of the booster will really need to wait until FDA and ACIP are able to review all the data that's coming in. It's just remarkable the amount of data that's coming in and is being published on almost a daily basis about these topics. So I would say to stay tuned when it comes to the interval or the timing in which someone needs the booster. In terms of the impact of it, I think that's also something that's still kind of evolving. The ACIP meeting, once again, that CDC external committee, they met on Monday. And one of the things that they really tried to walk through is kind of what does some of the data show now when it comes to the impact of Delta variant on vaccine effectiveness and who's impacted the most and who may benefit the most from getting one of these boosters. And so I think generally speaking, most of the studies have shown that there is a positive impact in antibodies when it comes to giving the booster, but we're still learning more in terms of what that means when it comes to preventing illness, right? And we also have to take into account any safety issues when it comes to the booster as well. So the next meeting of ACIP will really dive more into, well, what's the data behind these boosters? How well are they, truly boosting the immune system? And then also on the other side of the equation, what do we know from a safety standpoint? And just to forecast a little bit, what we do know from the additional doses for immunocompromised people, that was a recommendation that was made a couple weeks ago. The initial data from that does indicate that those people were able to get that third dose, and any of the side effects were similar to the first or second dose. So it wasn't like we were seeing any concerning safety signals when these individuals got a third dose.
Thank you.
Oh, and sorry, I realized I didn't answer one of your questions in terms of will this be combined with the flu shot? Will this turn out to be an annual event? I think that's all to be determined as well. Sorry, I know a lot of my answers are going to be stay tuned. We do know that there are other examples out there of vaccines where you get like 3 doses and then you're done. You don't need an annual booster. And then there are other ones like flu in which you do need an annual vaccination. So as of right now, we're really focused on this, this booster dose. And then in terms of if we will need, an annual vaccine or a vaccine, in some interval down the road, I think we'll need to see kind of what happens over the coming year as people study this and see what happens with our antibodies over time.
Thank you.
Great. I think the next question we received was from me. Is social distancing still needed? And if so, how has that changed? So yeah, as I said earlier, we continue to recommend that a layered approach to protecting communities and workplaces. I think it's really particularly important in workplaces because I think it's going to be very unlikely that everyone will be vaccinated or that you'll be able to know the vaccination status of everyone in a workplace. So we continue to recommend those layered approaches, and social distancing would be one of those. In addition to that, masking consistently and correctly, maximizing ventilation, and avoiding crowds when you can. So those are sort of still the tried and true public health measures that we continue to recommend.
Okay.
The next question, do we still need to worry about infections from touching surfaces? How much cleaning is needed? Yeah, so, originally when we were first learning about this virus, we did have fairly extensive recommendations around cleaning and disinfection. And as we've learned more, we have been able to modify those recommendations. So people can get infected by coming into contact with surfaces that have virus present. But based on the available epidemiological data and studies of environmental transmission factors, surface transmission is not the main route of spread, and it's really considered a very low risk. So what we've modified our recommendations, I think it was in the April timeframe, to just focusing more on cleaning. If you have high trafficked areas or high touch surfaces, you may want to clean more frequently, but we reserve disinfection more when you have a person who's been in an area who has COVID within the last 24 hours. That's when you may want to increase and disinfection is recommended. I will say, if you want to dig down a little more deeply on the topic, CDC has a science brief on cleaning surfaces or surface transmission. And we have a couple of, this has been a new approach. I think this is another one of the new and more innovative activities that we've done during this response that I haven't seen us do before, is try to outline a little more of the science behind our recommendations, especially when we're changing recommendations. So one of those was a science brief on surface transmissions, and I can put that in the chat link too. But we have a number of science briefs. So once you go on the website, you can look and see some of the other ones too. And I encourage you to read up if you want to get a little more detail on the topic. Next question, do you expect the vaccines to change to address the new variants?
Sure. Thanks, Lisa. So as I mentioned before, we're definitely tracking the new variants as they come out. I think, there have been different variants that have popped up around the world. And so CDC kind of closely tracks those variants and how they're impacting the countries in which they're spreading to kind of forecast and help us better prepare. So I think we're overall still learning about the variants for sure, still learning about how the vaccines interact with the variants and how they can protect us. In terms of changing the vaccines to address new variants, that's also something that is kind of to be determined. Right now, our data do indicate, and data from around the world indicate that the current vaccines do provide that protection, as I mentioned, against the Delta variant. But I do know that there are lots of people around the world, including in public health, scientists, the pharmaceutical companies, who are, if we do get one of these variants in which the vaccines don't protect against us, what can we do to develop a vaccine that will? And so that's definitely on folks' minds going forward.
Another question, let me pull back up. I tried to put the chat and the link in, but I don't know if the hyperlink went through. So let me try it again. I love these science briefs, by the way. We have one on vaccines and we have one on masks, and I find them really helpful. Okay. Can you mix vaccines? This is a question that I've gotten. I think people maybe initially get Pfizer, but then if they're thinking about in the future a possible booster, can you mix the different manufacturers for vaccines?
Yeah, so our current guidance states that the vaccines really aren't interchangeable. And I think that's a reflection of the fact that we want to make sure that folks are doing everything they can to use the same vaccine for both of their doses. So if you get Moderna the first time, you should do everything you can to get Moderna the second time, and the same for Pfizer. But we understand that in some situations that's not feasible. And so we do have some guidance on our website. Right now, the only kind of additional or third dose that's recommended is for people who are moderately to severely immunocompromised. And that's not really a booster. We're considering that an additional dose or a third dose. And for those people, what we say is that, if they can't get the same vaccine as they got for their first 2 doses, then they can get the other mRNA vaccine, so Moderna or Pfizer. I definitely think, some of that guidance may change or be clarified with the booster discussion because, obviously we have J&J, Pfizer, and Moderna. And so I think we've been getting a lot of questions of like, well, hey, I got J&J. What am I going to get for my booster? Can I get Pfizer or Moderna, and vice versa? Like if someone got Pfizer, can they get boosted with J&J? So I think a lot of those questions we hopefully should have some clarity on in the coming weeks. Once again, as FDA and ACIP review the data and make official recommendations.
Yeah, I've heard the comment that people feel that they were a little left behind because they received the J&J, and the J&J, because it received its emergency use authorization later, is a little behind in terms of people even receiving it. So there's just, the data has to catch up. We've got to have enough time from those initial vaccinations to learn more about, impact to immunity and potential for waning immunity. Well, this is an interesting one. Will the vaccine be in pill form in the future? I think this was probably someone who's scared of needles asked this question.
So that might be my son. My son is 14 years old, and I'm a pediatrician, just for background, and he is terrified of needles. It took 30 minutes for him to get the second COVID shot. So definitely understand that question and have some personal interest in it. But generally speaking, most vaccines are available through needle injections, or there's also some that can be administered by mouth or sprayed in the nose. Like, there's a flu vaccine that's sometimes used that's sprayed in the nose. But right now, the 3 authorized or approved vaccines in the US are all by injection. I think all the ones that are also in clinical trials at this point are also via needle injection as well. So I don't think there, at least in the US, that there are any kind of oral or pill forms of the vaccine that are in the immediate horizon. But I think that's definitely something that we'll continue to track as we go forward.
I think this next one's from me. Has there been any change in how long a person needs to be quarantined if exposed to the virus? And I do think this is a little confusing because now we have sort of 2 different populations. We have vaccinated and unvaccinated, and there are different recommendations that can be confusing. So I'll go through that. Again, just a reminder in terms of quarantine, you quarantine when you might have been exposed, and you isolate when you've been infected and you test positive. So just a terminology that sometimes people use interchangeably, but they are different. So the quarantine recommendations are dependent on your vaccination status. So people who are fully vaccinated do not need to quarantine after contact with someone who had COVID unless they have symptoms. So that's really kind of the critical piece, is to continue to monitor for symptoms. Fully vaccinated people, though, should get tested 3 to 5 days after their exposure, even if they don't have symptoms, and wear a mask indoors in public for 14 days following exposure or until their test result is negative. Now, people who are unvaccinated and have come into contact with someone who had COVID should quarantine for 14 days and then continue to monitor for symptoms. There are options, though, for reducing that quarantine. You can quarantine if you choose to, and based on local public health recommendations and other company policies or local policies, that after day 10 without testing, as long as you remain symptom-free, or you can, after day 7, if you've had a negative test within 5 days after your exposure. So it's a really kind of complicated algorithm, and probably why you need to pull it up on CDC and sort of walk through it like I do when people contact me for questions about exposures and contacts. But yeah, that's our standing recommendation right now related to quarantine. So that was the questions, but I did see one in the chat, and it's perfect for you, Kevin, with your pediatric background. There's one in the chat related to childhood vaccinations.
Yeah, and so for sure, I think one of the
Why don't you read the question, or let me read that? It says, is there any CDC data on the pandemic impact on childhood adolescent vaccines, including measles, HPV-related cancers, et cetera, due to the decline in pediatric and PCP office visits last year? What can employers do to educate employees and family members regarding this issue?
Yeah, and so I think one of the things that was a big topic of discussion for a lot of last year were some of the unintended consequences of the pandemic preventive measures that we put in place, right? So when we have folks, when we were recommending that everyone stay home and not go to the doctor unless it was an emergency, then that obviously has a variety of consequences when it comes to routine care. And I know that's not just specific to pediatrics, that also apply to other populations as well. But there have been several studies looking at how, ordering for the routine childhood vaccinations, as well as administration of those vaccines to children and adolescents did drop off a bit at the kind of height of some of those stay-at-home orders, and began to gradually rebound thereafter. So I definitely think that's top of mind for a lot of people in the pediatrics community. We do know that there's still, unfortunately, some children who are behind on their vaccinations, and that's definitely something that AAP has been actively messaging on, is trying to encourage families to make sure that they're coming back to their medical home, to their pediatrician or whoever they see to get their vaccines. And I think hopefully there was a lot of catch up done this summer. We all know children are have returned to school for the most part this fall, and so what we think happened is as a lot of the kids had their summer checkups, hopefully they were able to get somewhat caught up, if not fully caught up, on their vaccines. And so I think that's just something that everyone should be aware of. It's just encouraging all of those routine visits to happen. And once again, that's not just specific to pediatrics, but also to adults, older persons as well, is that any of those kind of routine medical things that we may have missed, I know I missed some last year, that it's definitely time to start catching up on those and making sure you're getting your dental visit in, your eye checkups, et cetera.
Great, thank you. We also have a question that's going to relate to presentation of some results I'm going to do immediately after the Q&A here. What are the recommendations regarding vaccine mandates and surveillance testing?
So maybe I'll start, and I'll definitely turn it over to Captain Delaney to see if she has anything. I think the vaccine mandate topic is definitely something that's getting a lot of discussion around CDC. Historically, those have been left to the local and state jurisdictions and private entities like corporations and companies. But I think one of the things that we're trying to look into is what does the data show on these? How could they be implemented? Is it feasible, et cetera? So I know Captain Delaney has thought about this quite a bit, so would love to get her thoughts as well.
Yeah, I mean, I think I've seen the evolution of employers' willingness to think about vaccine mandates. I mean, there were a lot of, at least initially, concerns around HIPAA and EEOC issues. And then I think, it really feels like the past 4 to 6 weeks, we started hearing more and more companies, Fortune 500, that are in some ways requiring vaccinations now. And I think largely in part to the Delta variant and this uptick in cases. I mean, CDC doesn't have a recommendation. I mean, obviously we encourage vaccinations. We want everyone to get vaccinated, but we really sort of delegate or defer the mandates and the requirements to private entities or local state jurisdictions. And related to testing, there's different purposes for testing. I I think, for this audience being focused on workplaces, CDC, we did issue guidance on non-healthcare workplaces and how the role of testing. I think that testing is going to become more important, both from, you test for two reasons. You test because someone has symptoms and thinks that they have COVID or has been exposed. There's also screening testing because some people don't know that they're sick. They don't have symptoms yet, but they can still spread and be contagious before they show signs and symptoms. So there's this screening testing and algorithms that can be put into place into workplaces to help catch those people and get them out of the workplace sooner so they don't have opportunities to transmit in the workplace. So there's a role for that, and some companies can explore the screening testing, incorporating some algorithms related to whether if you are asking vaccination status, the testing could be part of that protocol for people who aren't vaccinated. There's a lot of ways that you can approach using testing as one of the tools to help keep the workplace safe. I think especially now that last year we just didn't really see much flu because people were staying home and we didn't have those opportunities to transmit. And as we move into the fall season and people are returning to somewhat normal activities, we're going to start seeing these respiratory viruses spread, and we're not going to know if they're COVID or flu or the common cold or RSV. And we're seeing some RSV and PEDS, but so our recommendations say to screen for symptoms and monitor your symptoms and don't come to work. So more and more people have these symptoms. They're all really similar. I think testing is going to become more important, and employers are going to have to navigate how they're going to utilize testing to both allow people to come back to work. If they've said, I've had symptoms, I'm going to stay home, then are you going to have them test to come back in? Or, you're going to have to really build that into your plans in the fall, because it's going to be, we're going to be challenged with that more so than we have in the past.
Great, thank you very much. Well, let me lead into then the results of surveys that both NAWHC has done as well as Mercer. And so I'm going to share the results of these reports, and of course these will be available to all of our members later on. So with that, let me go through these for you. So NAWHC did a survey, and as you see, the employees were from a variety of sizes. These are all self-insured companies. We asked them how they offer services. Most offer on-site. Again, these are our members, so that's typically what's going to happen. I'm going to show you a survey from Mercer that's going to have all employers, not just those who have centers. Again, it's interesting to note, 82% are now offering virtual as well as on-site. We asked them, have your plans changed as a result of the Delta variant? It's almost pretty well split, that 45% have changed as a result of the variant, 55 have not. We asked them to indicate the policies they have or are considering. And the way you would read this graph is the green is those who currently have a policy. The blue would be those who are considering a policy, and the yellow those who are not considering it, and blue don't know. So looks like vaccine education is something that everybody is doing. Offering money as incentives is something that just a few groups are doing, perhaps about 27%. Giving time off is being offered by at least 64% of our members. Again, these are just the members of our organization. To mandates for all workers, only 9% are requiring it, but 55% are considering mandates. Mandating clinic staff to have, you can see 27% are mandating that those who work in the worksite centers have it, and 36% are considering that. Over 45% are asking for proof of shots prior to return to work. 36% are not going to consider that at all. Offering vaccines at the work site, over 73% are already doing that. Requiring shots for travel, only 18% are requiring, 18% are considering, and mask mandates is being required by virtually everyone. We'll get into that a little deeper when we get into the Mercer data. We ask about the policies for people who are not vaccinated. We see that termination is being considered or is in policy. Actually, these, again, blue is just being considered. And so no one is currently has that as a policy among our membership. Requiring testing at certain intervals, about 9% currently have that, and over 55 are considering it. Mandatory mask mandates if you don't have shots, then 55% are currently have that in place. For only remote working involved, again, we've kind of limited that. Only 9% currently have only remote people. Putting a surcharge on premiums. This is something that's being talked about a lot, charging more like you would for people who are smoking cessation, not being considered by over 55%, losing benefits not being considered by over 64% of ours. There is some consideration on restriction of travel, restriction on meetings, and how you treat people in general, no differences between those who are vaccinated and non-vaccinated. We ask about policies for those who have tested for COVID-19 and have not been vaccinated. Again, about 9% require proof of a COVID positive or negative test before coming back to work. 70% are treating people the same, whether they've been vaccinated or not, and 50% treated the same as those unvaccinated. Now, I'm going to transition to Mercer's survey. This is a lot bigger survey than ours, and it covers all employers who have those both on-site and not, who have on-site clinics and those who don't. As far as mandate goes, they find that 1 in 10 employers indicates that they have a mandate. 15% are requiring vaccines for certain functions, particularly those where you're contacting customers, compared to 3% previously. As far as mandated, looks like 14% be mandated for those working on site, 5% for those who are international, and then you can see for some others, the largest amount here, 71% are not requiring vaccinations for any employees right now. As far as incentives go, most of the incentives are for time off to get the vaccine, though 67% are not offering anything. Only about 10% are offering some kind of cash incentive, similar to what we saw through ours. As far as additional time off, 81% of employees have to use existing vacation or sick or other time. I think those with clinics, it's a lot different because we don't require that much. But you can see that there's clear direction here. As far as mask surveys, most employers, just like ours, are requiring masks, but in different situations here. So you can see the largest amount, 36, it's for unvaccinated employees, they have to wear masks. Vaccinated employees may wear masks, may work unmasked based on the honor system or self-certification. Unvaccinated employees must wear masks, and employees must be providing some proof for 21%. And all employees vaccinated and not offer max 24. So we can see that this clearly is a trend, and it's something I think that we still talk about. And you know, even though cities and states have their own mandates in different ways or requirements or limitations on masks, employers can do what they want, and that's what we're seeing here. Other safety measures that we're finding being put in place, 35% are decreasing on-site capacity due to tied to a certain percentage. 54% are maintaining social distancing, but limiting the number of people in common areas. 40% here are limiting visitors. 36% limiting outside meetings. 30% have a daily system checker, and 8% are requiring testing. So clearly a smaller amount. So in general, that's what we're finding. Lastly, transitioning employees who've been working remotely to back to on-site. 25% are allowing a phase-in period where employees can work 1 or 2 days. 45% are offering flexible time, allowing employees to choose. 16% are allowing a phase-in period to allow people to work on-site 3 to 4 days a week, and 15% just haven't a plan yet at all on this. As far as their timing to return to work, mostly 28% are already back full-time, 31% expected by the end of this month, 18% by the end of the year, and then a lesser amount, as you can see, for other times. 3% have no plans at all to return employees to their on-site during this year or even next. So if you want more information on this or other areas, please let me know, and we'd be glad to do that. So at this time, what I'm going to do is I'm going to go around the table for those people who are currently still on the board and ask you if you have any questions. So I'm going to allow you to speak and hope you do that. So I'll start just as you come up on my screen. So Anoop from Merck, you have any questions or comments? If not, I'll move to the next person.
Hi, Larry.
Yeah.
Thanks. My question has already been answered, but I appreciate it. Thank you.
Okay. Anita Brennan. Anita, do you have comments to or questions? Anita, no. Angelina Curley, any comments or questions? Okay. Ben Soap, Ben, any comments or questions?
None, thank you, Larry.
Okay. Debbie Heath, Debbie, any comments or questions?
No, thank you, appreciate it.
Okay. Emily Starry, Emily, any comments or questions? Emily, any comments?
I don't. Thank you very much.
All right. John Bussell, John, any comments or questions? No? Okay. Joe Thomas, Joe, any comments or questions?
Yes, I'd just like to say it was a very informative meeting, and I really appreciate the opportunity to participate with this. I really thought it was wonderful.
Great. Thank you, Joe. Katie Klimo, Katie, any comments or questions?
No, thank you very much.
Michelle Ardon, Michelle, any comments or questions?
No, thanks. Great presentation. Appreciate it.
Okay. Neil Karpas, Neil Campas, I'm sorry for mispronouncing your name, Neil. No. Okay.
No.
Sheila, no, go ahead.
That's okay, Larry. No, thank you. I was muted.
All right.
Great presentation. No questions. Thank you much for the invite.
Thank you. Sheila Schneider, any comments or questions, Sheila?
Hi, Larry. Sure, I do have a question for Captain Delaney. Just curious, just with, we're gearing up for a busy season here at Kohl's department stores. Obviously, we'd love to see more people, get vaccinated. We highly encourage it. With flu coming up, in tandem with people still not vaccinated for COVID. Just curious on what are thoughts on flu vaccine, same time, separated from COVID vaccine? Any input on that yet? Should you be getting vaccinated for both at the same time?
Yeah, and I don't know if Kevin's still on, because I think that the recommendations have changed since earlier when we were recommending time between. So can you fill that, Kevin?
Yeah, of course. So yeah, like Captain Delaney mentioned, early in the response or early in the vaccination guidance, we were recommending that there be some time in between the COVID-19 vaccine and other vaccines. That wasn't because of any data. It was just out of an abundance of caution and just wanting to make sure that if someone did have a side effect, that we were clear on which one it was from, either the COVID vaccine or another vaccine. But now we have changed that recommendation and have now said that you can get the COVID-19 vaccine at the same time as any of the other vaccines. There is some guidance on our webpage about you may want to administer one vaccine in one arm and the other vaccine in another arm, just to reduce the chance of side effects, and other kind of recommendations like that. But as of right now, we're definitely encouraging everyone to get the flu vaccine when it comes out, and also now we're also recommending that everyone get the COVID-19 vaccine, and you can get them at the same time. And I anticipate you'll see more about this coming out in the coming weeks.
Thank you so much.
Great. So are there any more questions or comments regarding that? Okay. Well, I do want to thank Captain Lisa Delaney and Dr. Kevin Chatham Stevens for taking time out of your day to brief our membership about these important issues. Do want to thank everyone who took time out for being part of the call. Remind you that next week, September 9th and 10th, the NAWHC annual forum will be held in person in Chicago. We will be requiring masks inside, as does the city of Chicago. But we encourage everyone to participate. Over 130 people registered, and we're looking forward to seeing you there. Lisa, we'll be getting back with you. Hopefully you have another update in another month or two, and hopefully we'll be in a much better situation than we are now. So thank you all again. So everybody stay safe and have a good weekend. It's been a pleasure being with you today. Bye-bye.